Introduction. The goal of this course is to teach you to recognize the major rheumatic diseases. Okay, the term connective tissue diseases is also used to describe rheumatic diseases since they can often affect joints and soft tissues. Another term that is used is autoimmune diseases since they have in common mainly an autoimmune physiopathological mechanism, not the etiology which in some cases is still unknown. Immune system. Set of organs and cells that have the function of protecting the body against external agents that are potentially dangerous. In the past, we used to distinguish between a reaction against the self and the non-self. The reaction against the self was always considered pathological, but now we know that we physiologically have to react against cell constituents, for example, during pregnancy to allow growth of the fetus and during wound healing. Generally, when the immune system recognizes the self, the consequence is energy, that is induction of tolerance. In wound healing, the leukocytes migrate to the site of damage, clear the cellular debris, and from this process of clearance, they receive the signal that makes them tolerant. Deficiency in the ability of macrophages to clear apoptotic cells is one of the features of the hallmarks of SLE. The major event that characterizes acute inflammation is the modification of the blood vessels. You have to remember that there is a crosstalk between endothelial cells and inflammatory cells. Modification of the blood vessels, which allows extravasation of leukocytes, is fundamental for the proper function of the immune system. We always need to take into account that in autoimmune diseases, the endothelial cells are activated, and this is why in these diseases we find an increased incidence of thromboembolic events, because endothelial cells control the beginning of the coagulation cascade. Inflammation leads to activation of endothelial cells, which leads to defect in control of clotting. Autoimmune reactions are organized exactly as a normal immune response. All the immune system is activated. For example, if you're responding against HBV, you will have activation of CD8+, CD4+, and B cells that produce antibodies. You always have the activation of these three branches of the acquired immunity. It's impossible to have the activation of only one of these branches also in autoimmune reactions. There are some diseases in which the pathogenetic events are mediated by autoantibodies. But along with the activation of these autoantibodies, there is also activation of T cells. Also, the opposite is true. For example, in diabetes mellitus type 1, the beta cells are destroyed by cytotoxic T lymphocytes, but there are, of course, also autoantibodies, which are not pathogenetic but are present, and their measurement, ICA, GADA, IAHA, and IAA, is used for diagnosis of diabetes type 1. You have to remember that along with central tolerance, there is also peripheral tolerance in secondary lymphoid organs and in tertiary lymphoid organs, which takes place throughout the whole life. In some patients that have autoimmune reactions, after a bad infection is resolved, there is the resolution also of the autoimmune disease. The immune system can change its reaction against a specific antigen. The choice of the immune system depends both on genetic factors, because there are some people who are more prone to development of autoimmune reactions, and on environmental factors. Autoimmune responses are not 100% related to autoimmune disease. Many can arise without any tissue damage. Autoimmune responses can be asymptomatic, transient, and also possibly useful. For example, rheumatoid factor, which is the hallmark of rheumatoid arthritis, is an antibody against an antibody, which can be useful because by making immunocomplexes, it helps the kidney clear the antibodies faster. We know very little about the etiology of autoimmune diseases. We know a bit more about the pathophysiological mechanism. Mechanism involved in autoimmune responses. We can have molecular mimicry, that is, an autoantigen resembles an antigen derived from a pathogen and becomes the target of the immune response. It's the basis of the rheumatic fever, following a Streptococcus pyogenes infection that is the development of arthritis and carditis. There is a genetic predisposition because each person's T cell repertoire depends on the MSC molecule, which are very polymorphic, and the array of peptides presented can make the difference in the development or not of an autoimmune reaction. We can have also broken barriers, access of T lymphocytes to immunological sanctuaries, eyes, testes, and CNS, which is however less protected than the previous two since inflammatory reactions can be useful for the reorganization of myelin, and contact with antigens to which they are not tolerant. If the barrier is broken, the possibility of development of autoimmune reactions is very high. Can have also polyclonal activation of lymphocytes. It's mainly mediated by superantigens, which are a class of antigens that cause non-specific activation of T cells through recognition of the antigen by a whole family of T cells, which uses a specific subset of V beta chain, resulting in polyclonal T cell activation and massive cytokine release. T cells are activated despite their T cell receptor specificity, and they are potentially autoreactive. An example is EBV infection. We believe that this mechanism is at the basis of the activation of T cells in rheumatoid arthritis. Binding of pathogen to self-proteins is another mechanism. The pathogen binds to the self-protein and favors the development of a specific immune response against the self-protein by acting as a carrier. This mechanism seems to be implicated in some interstitial nephritis. Can have infection of antigen-presenting cells, which is seen in HIV and HCV. Pathogenic classification. We have autoimmune diseases, so tolerance towards selected autoantigens is broken. Presence of both autoantibodies and autoreactive T cells. We can have also autoinflammatory diseases, which is a chronic inflammation in the absence of overt break of tolerance, such as in familial Mediterranean fever and Still's disease. Cells of the innate immune response that give rise to an inflammatory process. So here the innate immune system is involved. Target can be organ-specific, such as in autoimmune thyroiditis and type 1 diabetes mellitus. Tolerance is broken against a specific site, or it can be systemic, such as in SLE, RA, and Sjogren. The antigens that are recognized are ubiquitous and the aggression is systemic. The diagnosis in both organ-specific and systemic autoimmune diseases is still nowadays a clinical diagnosis, so the lab exams are a support. For example, in organ-specific autoimmunity, such as in Hashimoto thyroiditis, you recognize that a patient has clinical signs and symptoms of hypothyroidism. You detect that TSH is high and FT3 and FT4 are low, and at this point you search for causes of the hypothyroidism. You should never give a diagnosis of an autoimmune disease in a person who is asymptomatic but has positive autoantibodies in blood test. It's possible to have a diagnosis in a patient who is asymptomatic but has no autoantibodies. For example, 1% of SLE patients does not have antinuclear antibodies, but the opposites can be true. We have two types of thyroiditis: Hashimoto, in which the targets are thyroperoxidase and thyroglobulin, and they are autoimmune T cells, especially CD8 positive, and based Graves, in which the target is the TSH receptor and the mechanism is mediated by autoantibodies. The antibodies are normal antibodies and they are mainly IgG, rarely IgM and IgA. They are structurally indistinguishable from other autoantibodies. In some SLE patients, the overall burden of autoantibodies is estimated to be even up to 20% of total IgGs. How to detect autoantibodies? We can use indirect immunofluorescence, so ANA for ANA and anti-DNA. We can use agglutination assays that are less used nowadays for rheumatoid factor or Coombs assay, and ELISA, such as in antibodies against extractable nuclear antigens, antiphospholipid antibodies, antiproteinase 3, and anti-meloperoxidase antibodies, rheumatoid factor, and anticyclic citrullinated peptides antibodies. Indirect immunofluorescence. How does it work? The cells need to be fixed and permealized, because some antigens are inside the nuclei of the cells, and without being permealized, these antigens wouldn't be able to be reached by the autoantibodies, and then the patient's serum is added. Start diluting with a 1:80 ratio, and then you reach dilutions of 1/160, 1/320, and 1/640. The higher the dilution at which the autoantibodies are detected, the higher the titer of antibodies. You then add a second antibody which is bound to a fluorochrome, so you can see the signal. So these autoantibodies that react against self-antigens such as nuclear antigens are able to react with these antigens because these antigens, such as the DNA, is released after apoptotic cell death and NETs. There are some different patterns that can be recognized at immunofluorescence. We can have RIM, which is typical in SLE patients. Homogeneous, typical of anti-DNA antibodies, speckled and nucleolar. A given patient can have more than one pattern. Antibody detection is still very operator dependent, so this kind of exams should be performed in big hospitals that are used to performing a lot of exams. Sometimes in the past there were problems with ELISA. For example, considering the antiphospholipid antibody, it was very difficult to standardize the test because the autoantigen of the antiphospholipid antibody are often not the phospholipids per se, but proteins that bind to the phospholipid, such as beta-2-glycoprotein 1. This protein is present in the serum, and there were big differences between labs depending on how the buffer of the serum were used. And so there were different amounts of the cofactor, beta-2-glycoprotein 1, that were being added. We can divide ABs in pathogenic, pathogenetic, and non-pathogenic antibodies. Pathogenetic antibodies are the ones that cause direct tissue damage through antibody-dependent cell cytotoxicity, or antibody-dependent phagocytosis, or can cause immunocomplexes deposition or can interfere with the coagulation cascade. Non-pathogenic antibodies are not involved in pathogenesis and are used for diagnosis. Autoantibodies positivity does not mean autoimmune disease, but there are specific autoantibodies that correlate with clinical manifestations. Joints classification can have fibrous joints, such as in the or synarthrosis, as in the skull. The articular surfaces of bone are joined together by fibrous tissue. They are either immovable or slight degree of movement. You can have cartilaginous joints, such as in vertebrae. Bones are connected by cartilage, slightly movable, synchondrosis, symphysis. You can have also synovial joints or the arthrosis, such as in the hand and wrist. Bones are connected by synovial membrane. Synovial cavity contains synovial fluid and they are highly mobile. It's important to know the different types of joints because you will see that certain rheumatic diseases have a preference for certain types of joints. Fibrous joints are more affected by osteoarthritis, while synovial joints are more affected by rheumatoid arthritis. The enthesis is the fibrous tissue that connects the tendon to the joint capsule, and it's the target of spondyloarthropathies. An example is psoriatic arthritis, in which inflammation is localized on metacarpophalangeal joints and proximal interphalangeal joints, similar to rheumatoid arthritis. But through echography it can be recognized that these areas inflamed are outside the joints and they are entheses. The synovial membrane is normally so thin that it's difficult to recognize it with echography, but when it's inflamed, it becomes visible, and it is a sign of synovitis that is typical of rheumatoid arthritis. Until 10 years ago, X-rays were used for the diagnosis of rheumatoid arthritis, while nowadays ultrasound is used since the first sign of disease is the inflammation of the synovium is clearly visible with echo. With persistent synovitis, there is bone erosion, which is seen on X-rays, and it is something that nowadays with earlier diagnosis is seen more rarely. In osteoarthritis, the target is cartilage, with time and usage becomes less hydrated. Since cartilage has no blood supply, its tropism is given by the liquid inside the joint. Our diagnosis starts with the history of the patient and with family history and then patient examination. At this point, a hypothesis of diagnosis is made, and laboratory tests are asked to confirm or not the diagnosis. The history has to cover personal data, age, sex, ethnic group, and employment and habits, concomitant and previous diseases, articular manifestations. These have to be asked very carefully, and they have to include the pain and stiffness, signs of inflammation, and the pattern of involvement, which can be monoarticular or polyarticular. Addictive, which means that one joint is involved before another, additive. Symmetric or asymmetric, continuous or intermittent. The pain has to be localized precisely, since the inflammation can involve the muscle, the joint, or the periarticular areas. When the pain is present, we have to differentiate between arthralgia, pain with no signs of inflammation, and arthritis, that is pain plus inflammation. Between chronic and acute. It becomes chronic when it lasts more than 6-8 weeks, and if it improves with movement, which is suggestive of inflammation, or if it improves with rest, which is suggestive of osteoarthritis. Signs of systemic manifestations are fever, fatigue, weight loss, lymphadenopathy. Extraarticular manifestations can be present in the eye, such as uveitis, episcleritis, and dry eye, which is typical of many rheumatic diseases and is underestimated by patients. The effects of blood supply, such as in Raynaud's phenomenon, sign of vasculitis. We can have photosensitivity also, and abortions or other pregnancy complications. Through history alone, it's possible to differentiate between spondyloarthropathies and rheumatoid arthritis. Because in spondyloarthropathies, male are are affected as in females, and they are mainly young people. There is a classical spine involvement, so low back pain, tendonitis, enthesitis, monoarthritis, a history of infections, such as in reactive arthritis. Psoriasis also in psoriatic arthritis. In rheumatoid arthritis, instead, males are more affected than females are more affected than males. There is the incidence increases with age. Spine is paired, except atlanto-occipital joint, and we have a polyarthritis, which is symmetrical and additive. Patients with spondyloarthropathies are typically around 20-30 years old, while rheumatoid arthritis patients are a bit older. We have to differentiate between spine and peripheral joints, between large and small joints and between synovial joints and non-synovial joints. You also have to know the number of the involved joints. If it's only one, it will be monoarthritis. If it's a few, it will be oligoarthritis, and if there are many, it will be polyarthritis. Systemic diseases are symmetrical. If not symmetrical, you have to first look for a cause of local inflammation. The distribution of inflammation varies depending on the disease. The pattern can help in making an initial hypothesis. Rheumatoid arthritis is typically a polyarticular disease, symmetrical, additive, involving the small joints, and more frequently involves the upper limbs. Dolor and tumor are present, but calor and rubor are not present. In early rheumatoid arthritis, there is only swelling, while in late rheumatoid arthritis, there is deformity. Gout is usually mono or oligoarticular and more often involves the lower limbs. It presents with rubor, calor, dolor, and tumor. Ankylosing spondylitis and psoriatic arthritis usually affect the spine. They are peripheral oligoarticular and they are asymmetrical and present enthesitis. At inspection, you see swelling, tumor, and redness rubor. You check for joint mobilization. Pain can be felt only during movement or also at rest. Check for restricted mobility and joint instability. To palpation, you can feel the calor, the joint effusion, and the deformity. To differentiate between rheumatoid arthritis and psoriatic arthritis, you have to look at the localization. Distal interphalangeal joints here may be involved in psoriatic but are never involved in rheumatoid arthritis, and know that enthesitis is never present in rheumatoid arthritis but is present in psoriatic arthritis. There are also some acute phase reactants like CRP that rise in the initial phases and then decrease rapidly, while there are others like ESR, ferritin, and anemia. Macrophages are full of iron, so ferritin is very high, and there is anemia because the bone marrow has no iron to produce new red blood cells, which are long-lasting. It's also important to look at the appearance of the synovial fluid and check for leukocytes, making a bacterial culture and detect the presence of crystals. This can help distinguishing between inflammatory and non-inflammatory causes.